Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Imagine, just for a moment, stepping into probably one of the most intense environments in medicine. You're an on-call senior house officer, an SHO, in general surgery within the NHS.
Yeah, it's definitely high stakes. We're talking about a world where every single decision really counts. Time is absolutely critical, and, patient safety is right there hanging in the balance.
It's the definition of a pressure cooker.
It really is. And often these are, relatively junior doctors right on the front line. They're learning to manage huge pressure while making these vital decisions. It's a massive responsibility.
Absolutely. So in this deep dive, we're going to unpack a really practical, structured guide. It's designed specifically to help these frontline clinicians, well, not just survive, but actually thrive in that kind of environment. We'll explore how things like organization, efficiency, and really clear communication, they aren't just buzzwords, are they? They're actual life-saving principles.
That's right. Whether it's managing new patient referrals, reviewing inpatients who might be deteriorating, or even assisting in emergency surgery.
And what's really interesting here, I think, is that while this guide is aimed at surgical trainees, the core ideas, things like prioritization, gathering information systematically, documenting effectively, communicating, well, they're pretty universal, wouldn't you say?
Oh, completely. I mean, if you boil it down, it's about making smart decisions when you're under serious pressure. That applies everywhere.
Exactly. So whether you're managing, say, a complex project at work, or you're prepping for a big presentation, or maybe you're just trying to get more organized day to day, the insights from this on-call playbook could actually offer some really valuable lessons.
And the source for this.
Yeah. So our guide today is drawn directly from the on-call guide for surgical SHOs. It gives us this sort of rare glimpse into the practical realities of frontline surgical care.
Okay. So over the next little while, we'll dig into what an SHO on-call actually does, their core responsibilities, how they approach seeing patients systematically,
Right.
the critical art of good documentation, and that non-negotiable piece, communication and knowing when to escalate.
Okay, let's get into it then. So let's imagine our SHO. Let's call her Dr. Sarah. She's just starting her shift. First things first, she needs to get a handle on her role. Right.
Exactly. As the on-call SHO, you're essentially the first port of call for any new surgical referrals. These might be patients coming through A&E, or maybe referrals from GPs, and also for patients already on the surgical wards.
That sounds like a huge amount to juggle.
It is. Their main jobs range from clerking new patients, that means taking a full history, doing an exam, to reviewing surgical inpatients who might be becoming unwell. They also assist in theater, liaise with other specialties, and critically make sure all the patient info is documented properly and handed over. So their effectiveness really hangs on being able to prioritize, communicate clearly, and document everything meticulously.
That makes total sense. So with all that going on, I'm imagining the pager or the bleep going off constantly. That must be relentless. How do they possibly manage that stream of requests and approach seeing patients in a structured way?
Yeah, the bleep can be persistent. It really starts with triage and prioritization. Just like you try to sort through an overflowing email inbox, but with much higher stakes.
Right.
So for new referrals from A&E, they triage based on urgency. Is it, say, a suspected bowel obstruction that needs immediate attention? Or is it something potentially less critical, maybe like appendicitis?
Okay.
And then on the wards, reviews are often prioritized using something called new WS2 scores. That's the National Early Warning Score. It's a standard system using vital signs to quickly gauge how sick a patient is.
Right. New WS2.
Yeah. Plus, nurses' concerns or specific requests from senior doctors also feed into that prioritization.
So just thinking aloud here, like a patient's vital signs, tell an SHO when to escalate. What are the vital signs maybe in your own project or task list that tell you, okay, I need to flag this risk or this needs doing now? That's quite a neat parallel.
That's a great way to put it. And how do they keep track? Well, they log them. Literally note down the time, the location, the core issue for every bleep, and then triage appropriately. The guide really emphasizes using a simple system, could be a notebook, could be a whiteboard, maybe a digital app on their phone, just to track all those tasks.
Keeping a running list.
Exactly. It's all about maintaining a clear overview, making sure nothing urgent falls through the cracks. It's their personal to-do list, but, lives depend on it.
That's a really practical tip, actually, for anyone feeling overwhelmed with information. So, okay, they've prioritized, they finally get to see a new patient. What does a thorough and focused clerking actually involve? What are they looking for?
Right. So the clerking, this is absolutely crucial because it forms the basis for everything that follows. It generally follows a standard medical structure, starting with the patient's history. And this isn't just about why they're here now. It includes their past medical history, any previous surgeries, what medications they're on, any allergies, super important, and even surprisingly detailed sometimes, family and social history.
Like what kind of social history?
Well, things like smoking, alcohol intake, and even their occupation. Then they do what's called a systems review, a quick check on different body systems, especially focusing on the GI and urinary systems in general surgery.
So it's about getting the whole picture, isn't it? Not just the immediate problem. Why would something like, say, a patient's occupation be relevant in an emergency?
That's a really good question. It can give vital clues. For instance, maybe their job exposes them to certain chemicals or physical strains that could be contributing.
Ah, okay.
Or, knowing someone's a lorry driver might influence decisions about discharge or even certain medications, thinking about safety in driving. It just adds another layer to that diagnostic puzzle.
That makes perfect sense. Okay, what about the physical examination part of this assessment?
So the exam starts with just a general look. Does the patient look stable, or are they obviously acutely unwell? If they seem very unwell, they'll do an AE assessment.
Right, the AE.
Yeah, this systematic check. Airway, breathing, circulation, disability, exposure. It's designed to rapidly find and fix any immediate life threats. After that, or if the patient is stable, they'll do a focused examination, usually of the abdomen in general surgery. And, if it's appropriate for the condition, a PR examination that's a rectal exam. They also need to know when other specific exams, like checking for hernias or examining the groin, are needed.
Got it. And then come the tests, the investigations. What are the sort of standard basic tests an SHO would be ordering?
Yeah, so basic blood tests are pretty standard. Things like a full blood count, FBC, urea and electrolytes, UNEs, to check kidney function, liver function tests, LFTs, C-reactive protein, CRP, which indicates inflammation, clotting screens, and crucially, a group and save, GNS, in case a blood transfusion might be needed.
Right, standard bloods.
Pretty much. An ECG, electrocardiogram, is usually done if the patient's over 40 or has any known heart issues. For imaging, things like X-rays AXR for abdomen, CXR for chest, or CT scans, those are typically requested after discussion, either with the radiology department or usually with a more senior doctor, like the registrar.
Okay, now this next bit feels really interesting and, like you said, universally applicable. Documentation. Why is good documentation so critical? I mean, beyond just keeping records, especially when things are so hectic.
Oh, good documentation is huge. It's multifaceted, really.
Yeah.
And it absolutely mirrors why clear communication and record keeping are vital in any complex project or team.
How so?
Well, firstly, it ensures continuity of care. That's essential when patients are handed over between different shifts or teams. Think of it like your project notes needing to be so clear that anyone can pick up where you left off without missing a beat.
Okay, continuity. Makes sense.
Secondly, it protects the clinician, both legally and clinically. It serves as a record of their thinking, their decisions, their actions. And thirdly, it facilitates clear communication with the whole team, doctors, nurses, therapists. It shows professionalism and clear clinical reasoning.
Clarity, accountability, protection. Got it.
And the guide mentions using specific formats like SOP or SBR. Can you break those down for us? And maybe how they might apply outside of medicine?
Yeah, absolutely. SOP is a really robust format for documenting any patient encounter, and actually it's fantastic for structuring problem solving in almost any field.
Okay, SOAP.
Right. S is for subjective. That's what the patient tells you, their story, their symptoms. In a project context, maybe that's the stakeholder's feedback or the user's reported issue.
Subjective, got it.
O is objective. These are the hard facts. Vital signs, examination findings, lab results. In a project, this would be your data, your metrics, the observable facts.
Go objective. A is assessment. This is the clinician's interpretation. What do they think is going on?
Yeah.
The working diagnosis may be some differential diagnoses. For a project, this is your analysis of the objective data, your assessment of what the problem actually is.
Assessment. Makes sense.
And finally, P is the plan. What are you going to do about it? Further tests, treatments like NBM, which means null by mouth, or IV fluids. Crucially, the escalation plan, who needs to review and when, and clear task allocation. For a project, P is your action plan. Next steps, deadlines, who's responsible for what.
That is actually a really clear logical structure. SOAP. I can see how that would work anywhere. What about SBIR? You mentioned that too. That sounds maybe quicker.
Yeah, SBIR is often used for more urgent communication, especially for handovers or when you need to convey critical information quickly and concisely. It stands for Situation, Background, Assessment, Recommendation.
SBAR. Okay.
It's all about getting the absolute key information across efficiently, making sure nothing critical gets missed. Think of it like your elevator pitch for an urgent problem. Here's the situation, here's the relevant background, this is my assessment of it, and here's my recommendation for what needs to happen next. The guide also mentions specific templates, for example, for clerking new emergency patients, which list out all the key fields needed: name, referral source, complaint, findings, results, diagnosis, plan.
So templates to help ensure nothing's missed, even for someone new or under pressure. That makes sense. What about notes for reviewing patients who are already admitted? They probably need to be quicker, right?
Yeah, review notes are typically much shorter. They focus mainly on changes or progress since the last review. The example in the source is quite neat.
Go on.
So I'd say something like, patient reports improved pain, passing flatus now. That's the subjective bit.
Okay.
Then observation stable, abdomen soft non-tender, white cell count trending down. That's objective.
Right.
Assessment, improving post-op ileus. And the plan might just be encourage mobilization, continue current management, registrar to review in the morning.
So concise, focused on what's new.
Exactly.
Okay.
Efficient. You wouldn't rewrite the whole history every time. Just like in a project meeting, you wouldn't recap the entire project history daily. You focus on updates and next steps.
This brings up a really crucial point. Escalation. When do they know it's time to call for help from a senior? And what does effective escalation actually look like? Because this feels like the ultimate know your limits situation for anyone, really.
Absolutely critical. Knowing when to escalate, when to call the registrar or the consultant is paramount for patient safety. The guide is very clear on the triggers.
Such as?
Unstable observations like that NUWS2 score being 5 or more. Any signs of serious infection or sepsis. An acute abdomen, that means severe, sudden abdominal pain that's a surgical emergency. Significant bleeding, like GI bleeding.
Okay, those sound like clear red flags.
Definitely. Also, if imaging shows something really concerning, or if the diagnosis just isn't clear after the initial assessment, or simply if the patient seems to be getting worse despite what you're doing. And the key message, the really strong message, is contact your senior early. Don't wait until things are dire or you feel completely out of your depth.
Don't hesitate.
Exactly. It's much, much better to call for advice or review early. It's just like knowing when you need to bring in an expert or escalate an issue to your manager on a complex project before it spirals.
That feels like maybe the most vital takeaway for any high-pressure job. Yeah. And thinking about the end of the shift, effective handover, what's absolutely essential there to ensure nothing gets dropped?
Handover is another critical point. Again, using structured tools like SBR, or sometimes hospitals have specific electronic or paper handover sheets, is really highly recommended.
Structure again.
Always structure. The key things to cover are clear patient identifiers, obviously, their clinical background and any recent changes or events, any outstanding investigations or tasks that the next team needs to follow up on. And their escalation status, things like whether they have a do not attempt CPR order, a DNA CPR, or any other limitations on treatment. It's about leaving absolutely no stone unturned, ensuring the next person has all the information they need to just pick up and continue care seamlessly and safely.
I can see how vital that is for any team where continuity matters, medical or otherwise. The guide also mentions tools and technology. What are SHOs typically relying on these days in the NHS?
Yeah, they're definitely navigating a very tech-heavy environment now. Most hospitals use electronic patient records, EPRs, for accessing blood results, viewing scans, reading clinic letters.
Right, the EPR.
They use specific systems for requesting and looking at investigations. The names might vary, like CRIS for radiology info or PASS for images, but the principle's the same. A hospital bleep or phone directory, whether digital or printed, is still crucial for contacting other people and teams. And increasingly, there are electronic handover tools that need to be kept updated pretty much in real time during the shift. It's all about using technology to manage that flood of information more efficiently.
Okay. And finally, are there common pitfalls, things an SHO should really watch out for, the sort of biggest tripwires in this role?
Yes, there are several. And actually, many have parallels outside medicine, too. A big one is incomplete clerking. Missing a crucial piece of information like an allergy or not getting a full medication history.
All right, missing details.
Another is poor documentation. Maybe no timestamp on the entry, an unclear plan, or if they're still using paper, notes that are just illegible. A critical one, as we've stressed, is failure to escalate appropriately. Even if you're just a bit unsure, the advice is always ask a senior. It's far safer than guessing or hoping for the best.
Always ask.
Always ask. And finally, not updating the handover list properly, that can lead to missed tasks, maybe tests get repeated unnecessarily, or worse, it could actually lead to patient harm. These are all really lessons in meticulous attention to detail and proactive communication.
Okay, so let's try and pull this all together. We've taken a really deep dive into this high-stakes world of the surgical SHO on-call. And what seems clear is that while the environment is incredibly demanding, having a structured approach to patient care, to documentation, to communication, that's really the key, isn't it? It ensures safer outcomes and presumably reduces stress for the doctor, too.
Absolutely. We saw the huge value of triage and prioritization, whether that's responding to an urgent A&E referral based on how sick they seem, or prioritizing ward reviews using objective scores like NOWS2, those vital signs of deterioration, and using a simple system, whatever works for you, notebook or app, to just keep tabs on all those tasks. That's essential, just like managing any complex workload.
Yeah. And we explored what goes into a thorough initial assessment, that clerking. Taking a detailed history, including maybe surprising things like social history, occupation, doing a focused physical exam, and ordering the right initial tests, often after talking it through with seniors. It's about gathering the data first.
Definitely. We also highlighted why good documentation is so much more than just record keeping. It's fundamental for continuity of care, for legal protection, and for clear team communication.
Right.
And the power of those structured formats like SBP subjective objective assessment plan as a really reliable framework for any patient interaction, or using SBAR for those quick urgent handovers, they're just such useful tools for clear thinking and communication.
Universal tools, really. And maybe most importantly, we really underscored the absolute necessity of escalation. Knowing when to call a registrar or consultant, unstable patient, acute abdomen, diagnostic uncertainty, and doing it early. That seems paramount.
It is. And we also touched on avoiding those common pitfalls, incomplete assessments, bad notes, failing to escalate, poor handover. It all comes back to diligence and communication.
So this deep dive into the SHO's world, it really seems to show that it's consistency, it's practice, it's having that systematic approach that builds speed, sharpens judgment, and ultimately builds confidence under that immense pressure.
Yeah, it's about developing a reliable mental framework, a routine that you can fall back on even when things get chaotic.
So here's a thought to leave you with. What if you were to try and apply the same level of, say, structured thinking, meticulous documentation, and really clear communication to a complex problem or maybe a project in your own life? How might thinking like an on-call SHO, prioritizing ruthlessly, documenting clearly, knowing when to escalate, how might that transform how you manage information overload, make critical decisions, or navigate your own high-pressure situations?
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.